Okay, let me start you.
Okay.
Hey, so today, guys, we're gonna talk a little bit about respiratory failure. I have my colleague and fellow nurse practitioner, Sarah Martinez, here to discuss respiratory failure. So, Ms. Martinez, what do you think about when I say respiratory failure? What do you think about?
So I first picture a patient being in respiratory distress. They are not looking good. They're tachypnic. They're pale. They may be even turning cyanotic. And as a nurse, you want to identify those signs and symptoms because then you can call for help, call for rapid response, and perform your nursing interventions to help resuscitate and improve the condition of your patient. But if you were to get into the criteria of respiratory failure, it is hypoxemia, hypoxia, or hypercapnia or hypercapnic. And so, Isaiah, tell us more about respiratory failure, the criteria.
Yeah, so I think it's important when you're teaching this stuff, when you're highlighting high levels of CO2 versus low levels of oxygen. Mm-hmm. And I like to always stress to our students, the only real value of getting an arterial blood gas is if you really need to know their oxygen level. So with hypercapnic respiratory failure, we're going to have a high CO2 level, usually above 50 is like what we classify as hypercapnic failure. And then for a hypoxic failure or hypoxemic failure, when it's bloodstream failure, we would have like a 50-50 club. So their oxygen level could be below 50. Technically, when you get into the 70 range and lower, we start to put them as hypoxemic. But I like to always stress that the patient, when they're in hypercapnic respiratory failure, they are having a ventilatory failure, meaning that they're not breathing well, so their respiratory rate and their amount of tidal volume is dictating their CO2 level. So we always like to separate those, you know what I mean?
So when you're discussing tidal volume, that means we're taking a deep breath in and out. And when they're in respiratory failure, they become shallow breaths and fast. So that means they're not getting good oxygen in and they're not expelling that CO2 out. And CO2, when you build it up, it starts depressing the respiratory system. And also they're getting less oxygen. They get confused, irritated. They're not at their level of consciousness baseline. And their orientation as well is disoriented.
Good. So what do you think, and this is something I get asked a lot, will a nasal cannula or a non-rebreather, will those ever help a CO2? Or do you need more of a ventilatory support?
So if you're looking at solely oxygen, it will help with oxygenation, but also the issue, because they usually go together, oxygen problem and CO2 problem. But that CO2 will still be building up as they're in respiratory failure and they're shallow breathing. So yes, we're helping the oxygen, but we're not getting rid of the CO2. But honestly, what Isaiah is saying, if their tidal volumes are not good, breathing is not good, that oxygen is going to be hard to get into the bloodstream and have that gas exchange.
Good. So as we're moving through these topics, there's some things I want to definitely highlight today. Can you talk to us a little bit about when and why to intubate? What would make a patient, when we're working as a nurse, what would make us say, hey, this patient should be intubated?
So as we were talking about like nasal cannula, non-rebreather, we know we shift to BiPAP because BiPAP will help open up the lungs, help with the tidal volume, expel the CO2, and readily get the oxygen in the blood. But the issue is if the patient cannot maintain their own breathing, they're eventually going to stop breathing because they cannot keep up with that energy. They get fatigue, shallow breathing, and then they eventually stop breathing. So intubation, one of the indications is if they cannot maintain their own breathing. Another indication is if they can't protect their airway. So as their level of consciousness decreases, can they swallow their own secretions or are they going to aspirate on their own secretions? So like those are the two prominent things that I see in practice. Can they protect their airway and can they maintain their own breathing? And when you see the patient struggling to breathe, the non-rebreather and then BiPAP, and they're still struggling, those are indications that they need to be intubated.
Now, would there ever be times, because I'm thinking back as an ER nurse and working in the ICU, is there times that you ever see where you just skip BiPAP and go straight to intubation?
Yes. So they're tachypnic, very shallow, they're pale, they're blue, the oxygen is very low. We get an ABG, they're in the respiratory failure guidelines. Their O2 is less than 60, their CO2 is greater than 50. And we know at this point, BiPAP is not going to be enough to help their breathing tidal volumes and correct that fast enough. So we will have to intubate before BiPAP. So.
Very good. And you are more than welcome always to ask me a question, but can you walk me through, I think as a nurse, that can be like a very terrifying thing when we're going in and we've never been a part of that intubation process. What does that look like for our role? Like, we know the provider or the RT is going to intubate them, but what do I need to do as the nurse?
So as the nurse, it depends on where you work, because respiratory does have a very active role in managing the airway. But so, depending on the hospital, you may be part respiratory until they come to help you. So if your patient is at that point where they can't maintain their own breathing, level of consciousness is decreased, you may have to start bag valve masking them to get that ventilation, 100% oxygen, 15 liters, call for help, call for rapid. Then when respiratory takes over, you can help get the sedation meds, paralytic meds. You will have to verify those meds with another nurse and the provider. No, we cannot push paralytics or sedation meds except for Versed, but we cannot push propofol, but we can help draw up and identify the dosages needed.
Yeah, and what she's talking about, I want to make sure to highlight, that is specific for where we're practicing here. So you may work in an area that you are allowed to push different medications based on your hospital policy, state practice guidelines. I would always make it a very good habit, if you are permitted to push paralytic drugs, that you announce that overhead. Something that I used to always do is if I said I'm pushing a paralytic, I would say, hey, we're all aware the patient's going to stop breathing in 5 seconds. So that everyone is on the same page at the minute I push this, breathing stops.
And don't feel like, that seems silly to communicate that, because if they stop breathing and we don't have the right resuscitation measures, they could code on us, and that's not what we want. And so you want to close that feedback. As y'all learned in BLS, ACLS, if you've taken ACLS as well, we want to close that feedback, make sure we communicate back and forth clearly what we're doing, what we're giving, and even pause for a second, because that pause is your safety measure.
Yes, it's always good, and I stress this. I had a great mentor through NP school, and he used to always, before we ever did an intubation, we took a moment and said, why are we intubating? What's the need to intubate this patient? So walk us through. I'm going to walk back a little bit. We didn't go through it. What do you see as the benefits if I'm learning about CPAP versus BiPAP? They both have letters. What's the difference?
So CPAP is continuous positive airway pressure throughout the whole respiratory cycle. BiPAP has positive pressure on inhalation and exhalation. So we can control those pressures on inhalation and exhalation, where CPAP is a continuous pressure. And there is 2 different CPAPs. There's one on the ventilator and one at home. And I'll let Dr. Moser describe more about that.
Yeah, so something I always like to stress, when you have a bilevel positive airway pressure, you basically can ventilate the patient. And by that I mean, if your patient stops breathing on bilevel airway pressure, they're going to be vented. So that's always a scary thing. I always tell new nurses too, and you guys should know this, when you are assessing your patient, if they went from a respiratory rate of 30 and they're on BiPAP, and you walk in and their respiratory rate is 12, they have stopped breathing, right? Because the machine is going to breathe for them. Versus CPAP, they're going to get that continuous pressure, but there's going to be no pressure that's going to cause them to ventilate, if you would. So that brings us to an important point with the nursing aspect, is that patients must be conscious and ready to be on BiPAP. And that's one of the big criteria. It's like, hey, our patient lost their consciousness or they're vomiting. That's another big one. They can't maintain their airway. We need to go into the intubation. We always have to separate those two, and I think that's something hard when we're first learning this. The breathing tube could be just for an airway issue, such as angioedema, crush injuries, stridor, an airway issue, or the intubation could be because, like what we saw a lot of with advanced COVID, and their lungs are horrible, and we're having to do forced pressure just to get minimal oxygen requirements met. So as we're moving down here and we're talking about intubation, The next thing I wanted to bring up with you, Sarah, was the modes of ventilation, and we wanted to keep this simple.
Yes.
So let's try to keep it as simple as we can. First, let's start with what mode of ventilation does pretty much every patient go on? They got intubated. What mode are they going on?
So you're going to hear this acronym AC, so assist control, volume control. So we're really focused on their volumes, their respiratory tidal volumes. Yes, it can control their respiratory rate. It can control their tidal volumes, control their oxygen they're receiving, and it can control the P. So there is different settings within that. But it is focused on their tidal volume and helping with that gas exchange of oxygen and CO2. But I'll let Dr. Moser describe more about assist control.
So like assist control, I like to always stress that this is like the patient has to do nothing. There's no work associated with this. If they take extra breaths, the machine will help them. But the reason this is like the initial, why we like it so much is that we can set and demand a volume.
Yes.
And that's the biggest thing. When you guys learn about ventilators, just the basics of them. Now we've gotten a lot of advanced settings, but the general premise was we either control the amount of pressure going into their lungs or we control the amount of volume going into their lungs. So assist control does that. It gives them a set volume, usually around 5 mLs per kilo, 5 to 7. Sometimes we do low tidal volumes for certain conditions. But, you know, you see the typical ones. You know what I'm about to say. When you work in the ICU, you see the typical ones that every patient goes on 500 of tidal volume and they get started.
That's the standard average. If you were to look at Dr. Moser and I, Dr. Moser is taller. Yeah. He has a bigger body mass. Yeah. So once they calculate the actual kilos per mLs, he'll have a higher tidal volume. So he'll probably be above 500. I might be around 500 or below. But the average is 500, what they start out pretty much everyone on, because that is like the safe range. Because we can over-distend the lungs, and we don't want to have volume trauma.
So we talked a little bit about assist control. So assist control, to highlight some of the key components, that is when we're giving a demand volume. So they're going to get a set volume amount. And if they take some extra breaths, that ventilator is going to help give the rest of whatever volume they needed.
Yes.
And I think that that's a good summary of assist control. And I hope we all sitting at home thinking about this as we're listening, if you're on that mode of ventilation, you should be sedated. Yeah. So this is not an awake ventilatory.
Just imagine having like a straw in your mouth and then it's all the way down your airway. You know, you're going to want to automatically pull it out. It's uncomfortable. Yeah. You're going to gag. And also to add, when Isaiah is talking about breathing over the ventilator, that we do say that as the patient breathing over the ventilator, because that sometimes lets us know, oh, they're starting to do their own work of breathing, or it could be a sign that they are struggling, they need more sedation. So we have to assess the patient, look at your patient, inspect them, you know, follow the tubes and lines, then look at the settings. Is it too fast? Is it too high? Is your alarms going off? That's what he means by breathing over the ventilator. You can actually see the set respiratory rate. Let's say it's set at 12, but now that it says the total is 16, so they're breathing 4 over that 12.
Yeah, and I think that's important when we're trying to wean them, which gets us down to our other, you know, as we're doing big concepts today, thinking our other type of ventilatory status, our ventilation method that we use is pressure support. So why is that a great option when we're taking people off of the vent? So why do we look at those things when we're taking them off?
It helps with expanding their lungs, keeping the alveoli open. It helps with that gas exchange. Because again, the two things we look at is oxygen and CO2. If you're really to focus, those are the prominent topics in respiratory failure. We're really trying to increase that gas exchange, balance the CO2, exhaling it and receiving the appropriate amount of oxygen. So that's what we're really trying to do.
And a key point to take home with that too is that as our patients coming off the ventilator and looking at some of those criteria, like, are they over breathing the vent? Has their ABG been corrected? Have they clinically resolved the reason they got put on the vent? That's probably the biggest one that I highlight. If the patient got put on the vent because of angioedema from an allergic reaction, and the angioedema is resolved, and that gets us into like a cuff leak. Can you talk a little bit about that real quick before I finish the cuff leak, what that is?
So the cuff leak, when the patient becomes intubated, there's a cuff a balloon, and that helps hold the tube in place. Yes, we do have straps around the tube that goes over the face, and that will further hold the tube in place. But also the cuff will also help maintain tidal volumes. So if we put air into the tube, into the lungs, the air is not escaping around the cuff, and they get their appropriate tidal volumes. However, we're happy when we hear a cuff leak when the patient, the ABGs are within range, the vent settings are low, they're at the starting range. The patient, you inspect them, they actually look like they're not in distress, their vitals are okay, labs are okay. So when the cuff leak happens, the angioedema, once that is resolved, it's decreased. So now there's room for the air to go around the balloon and escape. And you can actually hear the cuff leak sometimes too. And then yes, the respiratory has their device to check the pressure. So if we hear that and everything is within status quo, within normal limits, we might be able to extubate the patient. Yeah. But basically the angioedema is resolved, that swelling is down, and now that balloon has space and we can hear that air escape around.
Good, and I always stress that too, and I know you do too, like ready to wean, ready to come off of a vent, you have to fix the initial injury. So if the initial injury has not been resolved, an example would be if your patient was in septic shock and it was from a severe intra-abdominal infection. If we don't have source control and fix that intra-abdominal infection, we're never going to get them off the vent.
What they say is, treat the underlying cause. And this is very true. As you know, abdomen, if the abdomen is distended, infected, that will affect your respiratory volumes and rate. But also, it's systemic now, the infection, and it SIRS. It's an inflammatory response throughout the body. So now your respiratory system is affected. It's trying to maintain that gas exchange, and your body's trying to fight that infection.
Yeah, so let's move a little bit more. I think intubation's a very needed thing in many conditions. An example would be like if you don't intubate them, they're going to die, right? So the other side of that is when intubation is either not indicated because the patient has made their wishes known through a DNR, or if a little bit of, maybe initial intubation's done, but then we say, hey, let's terminally extubate. So first, can you walk us through what is a terminal extubation?
So first, like advanced care planning, you want to know their DNR status or code status. Are they a full code, DNR, do not intubate? Also, do they have a living will? What are their life goals, their end of life goals? Do they want to be intubated? And also, this can be temporary. The tube does not have to stay in place. So let's say a patient and their family decides that they want to extubate and do end-of-life measures, comfort measures, then we're going to call that a terminal extubation, because without the tube, they will eventually pass away. They will eventually die. So we call that a terminal extubation. So with terminal extubation, we have to, usually in the hospital, we have to have two different physicians sign off saying they have a poor prognosis. These are the family and patient wishes to go on hospice, end-of-life care, comfort measures. We have a DNR in place because if they do pass away or, they stop breathing, we don't want to have to initiate CPR because their goal was to pass away and have comfort measures. Do you want to further describe?
Yeah, so I think and this has become, and I know it does for you too, because she had a background in hospice and dealing with a lot of this stuff, and now I work in geriatrics and kind of transition a lot of these patients to hospice. I think it's important whenever we're talking about care planning, we have to do that when the patient's healthy. So that's the best time to do it before they ever hit the hospital. So looking at the DNR, specifically speaking for Florida, so we're going to talk about here where we both practice, a DNR withholds CPR, withholds the ventilator, withholds intubation. So that's the basis of a DNR, and I like to highlight this. It can be signed by an NP. I make sure everyone knows that. If you're an NP out there,
this is true.
It can be signed by an NP. And then terminal extubation, just kind of walking you through that process, what that looks like is we've said, hey, this patient's not getting any better. The family or the client prior to them coming into this phase expressed their wishes. And we try to transition them very nicely. And by that, I mean, before we pull the tube, and I'm sure you've done this a lot, we'll give them medicines to help with their secretions, like scopolamine or some atropine drops. And then we'll give them sedation meds so that they don't have like anxiety.
We could do Ativan, morphine. That'll just help calm them down, not feel like they're in distress, that they have to rely on the breathing tube. We can actually just put a nasal cannula for comfort. A little bit of oxygen will actually help decrease that anxiety too.
Yep.
It's very non-invasive measures. And if you were to think of yourself, what would you like at the end of life? You don't want a BiPAP machine. You don't want these big masks or tubes and lines in you. You want to be really comfortable.
Yep. So that really highlights end-of-life care, because we know as nurses, like, our responsibility is to take care of our patient, and that first thing we all sign on for, which is do no harm. And so many times you guys are going to see this in practice, and I know we see it all the time, is the patient ends up having more harm by all the procedures that we do. And I always say, like, think about it, like when I put a central line, or one of our colleagues put a central line in someone's neck, that is not a painless procedure. Of course we put lidocaine and all those things, but if you've ever had lidocaine or you've seen it given to a patient, it burns, it hurts, that's a painful procedure that many times our patients wouldn't necessarily need. So the one thing I wanted to talk about with end-of-life care, moving to palliative, is some of the controversies that we've had. And I wanted to bring it back because when we were working on this, I was thinking about, and I don't know if this happened to you in the ICU too, but there was a lot of controversy surrounding COVID intubations. And one thing I kept seeing was, not only did when we intubate them, of course we knew the mortality rate was going to go up. Like, that's true for any condition. If we intubate you, it's because you're critically ill. But I don't know if you ever saw some of the controversy. Like, I remember I had a patient's family telling me, hey, you're trying to intubate them so that they die. And we were sitting there. Did you ever have something like that?
So I did have a case like that actually in clinical with the students and a family. And I think why people associate that with death is because they are critically ill. And it depends on their condition at the time, their comorbidities, how much their body has taken a hit from being sick, and if the body can recover, if the organs are shutting down. So I think that's why people associate death with intubation. But really, intubation, it can be a resuscitative measure. However, the patient is critically sick at that point. And when families ask me, like, do you know the prognosis? Sometimes we don't know. It's a day by day, hour by hour. And we just have to keep assessing and seeing, are their numbers looking better? Are their settings going back down, titrating back down? So that's how we can tell if the patient is getting better. But really, it's just like CPR, if you want to look at it that way. It's another resuscitative measure. But when you get to that point, they are very sick and they have multiple comorbidities. Their body is it's declining.
And I remember telling families all the time, and it was tough. Like, don't get me wrong, like, I saw it on TV, but it wasn't real until they actually brought, like, the refrigeration trucks during COVID-19. And it was horrible. I mean, we had so many patients passing. But I used to always remember we were intubating multiple people a day. I mean, it was a lot of intubations. And I used to always tell the families, I would say, hey, listen, like, I wouldn't want to do this if we didn't have to. But we're getting into what we talked to at the beginning of this podcast, which was they have hypercapnic and hypoxemic respiratory failure. What do you do? And this is where it brings into, like, more advanced management. These patients, even after being on the vent for multiple days, then we kind of went down the pathway of, do they go on ECMO or do they go paralytics, and we take away all of their ability to breathe? And
what he's talking about is now it's almost a last resuscitative measure. The reason why I'm saying it that way, because it is like a treatment. It is, we're trying to resuscitate them to get them back to their baseline and get them off of these invasive methods. But once we max out the ventilator settings, we max out their FiO2, what oxygen they're receiving, the PEEP, they're maxed out at 20, and there's complications with that. Then we start looking at other options to help with the hypoxemia and hypercapnia. We're trying to improve that gas exchange. So we might paralyze them because now the ventilator's in more control, and we can do a different setting to help, more advanced setting to help with that gas exchange. And at that setting, it's very uncomfortable. It oscillates. They're breathing at 400 breaths per minute. We're really trying to get that oxygen in. And then they may also add nitric oxide. And then ECMO is another last resort because we're really trying to improve that gas exchange. And then ECMO can also improve blood pressure. There's like different settings with that ECMO, but.
So what do you think? It makes me think about, I don't know if you watch ever the EMS shows from, and you guys know my background as a medic, but other countries have it where they are doing ECMO in the field. And they're having great numbers because when you look at ECMO, like it's honestly the best of both worlds. The patient doesn't really need to have any pulse activity. They don't need to breathe. And we take all their blood out and put it back in fully oxygenated and take out the CO2 and all the toxins. So you look at it like ECMO, if we could make it more accessible,
more portable,
more portable, make it easier to put in, you know what I mean? Train a lot more providers.
Almost like a dialysis. It's almost similar to, if you were to think of ECMO, it's similar to dialysis, or similar to when they do open heart surgery too.
Yeah, they put them on bypass for a little bit. But the way I think about it is like if we, transitioning respiratory failure, if we could mainstream ECMO to make it easier, more accessible, that would be the golden treatment for almost everything. Like if you think about it, if you didn't have to do like compressions for a long period of time, it could immediately provide oxygen to the brain.
The perfusion, your perfusion's already restored, then you have your gas exchange, oxygen to the brain. I'm already imagining like we have a portable defibrillator, we have portable ventricular assist devices that people walk around with. We could do portable ECMO, but there is complications with that. We're worried about clotting, we're worried about infection. So definitely the logistics and processes will have to be closely looked at.
It'll have to come around. Now, tell me, what advice, and we're going to walk you through a case next, because I always think shadow boxing is some of the best way we learn stuff through cases. What advice do you have for our nurse learners that are either coming into the field or maybe they have some experience as a tech and they're transitioning? What advice do you have for them in the initial resuscitation phase of respiratory failure? Like, what do you tell them? Hey, this is what the need to knows.
So the need to know is, I know when your patient becomes in distress that like you do freeze up, and that's okay if you freeze up. Just take a moment and breathe, and then you got this. Call for help.
You got to breathe because they're not breathing.
They're not breathing. Yep, exactly.
You got to breathe.
And so call for help. You could call rapid, depending on where you're at, call a rapid response. But usually I'll sit the patient up to help with their oxygen, to help receive that better, get rid of CO2, whatever mask device is nearby, nasal cannula. I may have to go get a non-rebreather. But at this point, when they are in respiratory failure, I'll skip the nasal cannula, Venturi mask, and go to the non-rebreather, because that's almost 100% oxygen. So I will put that on them. Depending on their level of consciousness and their breathing, eventually you may have to lay them back down and do a bag valve mask if they're not ventilating well and they are basically almost in a comatose state. But, call for help. Your nursing measures. Now you just have to do it. And it's okay to just pause for a moment and breathe and just go ahead, do what comes to your mind first. You set them up or you put your oxygen on, you check their SpO2. It's okay if it's not quite in order. I know for your nursing exams and NCLEX, we do have priority questions.
What do you do first, Ms. Martinez?
What do you do first? So, and again, it depends on how the question is worded and what it's asking. But, in practice, you see us doing those interventions all at once. They just start going one by one. We start going through it. And you'll have helping hands, too. But what would you add to that? Or what would you...
I think the key takeaways is and I always say this, prepare for that day so that you can be calm when it happens.
Yes.
So over-prepare so that you're calm when it's going on. Like if you're freaking out, you can't help the patient.
Yeah.
So always be calm. Respiratory failure is a developing condition. So early signs and the data, and I know you know this, the data continually supports that tachypnea is the #1 predictor of death. So when your patient comes in and they're tachypnic, do a real respiratory rate, right? You know what I'm talking about. Like don't put 16. Like count the respiratory rate.
And it's okay if your assessment is different than, say, when Isaiah comes in, he may get 32 and I had 28, or I had 22 at the time. It's okay.
Yep.
This nurse practitioner, when I was actually in my FNP clinicals and I was at a pediatric office, she's like, people don't realize the patient changes. It's okay if your assessment is different, because it's not going to be even the same minute by minute. You know, something can really change in that minute by minute. So don't feel bad that your respiratory rate was off. That was what you got at that time. But that's what we like, though. I like to see trends. I like to see, oh, wow, now he's up to 32. Now he's going up to 36 or 40. He's getting worse. You know, he's not doing good. Yeah. So it's okay if you have a different respiratory rate. And you can always double check to whoever's, you know, next to you, or grab, like, is this what I'm really reading? Yes, people do have anxiety patients. So if you stare directly at them, I'm going to make them breathe faster because I'm really looking at them. Yeah. So remember the techniques that you learned in your health assessment lab of how to do a respiratory rate without making them feel anxious too.
Yep. I know I had a case not long ago where the nurses were documenting 16 respiratory rate. And I walk in there, and it's interesting because a lot of facilities, I know you've seen this probably too, the techs document a lot of the vital signs data. But you as the RN have to validate the data being provided by the unlicensed personnel.
Remember, you manage the techs and LPNs, so that is you are in charge, you're supervising. So even though the tech documented that, if you signed off and you get pulled into court, that's your license. And also it's patient safety. Yep. And what Isaiah's talking about, this is quite an ethical dilemma that we do see sometimes in practice. Yep. You know, we just get comfortable in our practice. We're like, oh, the patient looks fine, respiratory rate 16, but is that really valid? Is that more falsifying the records? So just take that minute. It only takes a minute, even your 30 seconds to count the respiratory rate, and you can see that accurate.
And something I'll always, and this might be a little clinical pearl, going back to my what I was talking about with the story is like the guy, they kept diagnosing 16 on the patient, and I walk in, it's like 45, and I'm like 16 to 45, like that's not a thing. But one thing that I would always suggest is like, if you're putting your patient on oxygen, their respiratory rate is probably not 16, because what is the first thing you do when you're hypoxic? You breathe faster.
Yeah, and you want oxygen.
You breathe. You keep breathing faster.
Because you're trying to get that oxygen and get rid of that CO2. So that's why you're breathing faster. You're like, I need that oxygen. I need to breathe.
So most patients that, like, I'll see sometimes the staff will document that they applied 2 liters of oxygen, but then the respiratory rate's normal. And I'm like, it could be. I'm not saying that's not possible. But usually when patients are acutely hypoxic and short of breath, your respiratory rate doesn't stay normal.
So I'm laughing because I'm looking back at all the patients that I've taken care of in respiratory distress, failure. And it's true, like if they need oxygen, they're usually, what I've seen is they're above 20. They may be closer to 30. But so they're usually not 16 unless they just took a deep breath and they just relax for a moment, but then they go back up again, so.
And the one thing it always cracks me up, they used to ask me, Isaiah, why do you have more sepsis patients? And I'm like, I don't have more sepsis patients. I document real respiratory rates. Because the respiratory rate is like the biggest criteria for all the hospitals pretty much for sepsis. And so if you got a patient with a 26 respiratory rate with a fever, they're going to hit almost everyone's criteria.
And he just brings up a valid point. You know, like we have better screening methods these past years, these past decades. We have better screening methods. So people are like, why is there more of it? Well, it's not really more of it. It's always been there. It just now we have actual better screening methods and we're actually implementing them and now we're catching them. And our goal is try to prevent them from coding. We don't want them to get worse. So that's why we have the screening methods, because we want to improve patient outcomes and decrease those mortality rates. So.
That continues to reign true, even with things like heart failure, early detection, and so let's go through this case now. I'm putting you on the spot with this case. She has not read this case, so. All right, so Mr. Thompson, this is your case here. 68-year-old man with a history of COPD and hypertension who presented to the emergency department with shortness of breath, increased sputum production, and 2-day history of low-grade fever. On arrival, he's tachypnic. The nurse took a good respiratory rate of 32 breaths a minute. using accessory muscles, and oxygen saturations on 88% on a non-rebreather. So first, what do you think? And if you're watching this, this is where you guys need to pause the video, pause the podcast if you're listening on audio, and say, what do I think is going on with this patient, and what is the initial resuscitation that is needed? Now we're going to talk to our expert here. What do you think? What do you think is going on with him just right off the bat? What are some conditions you can think of?
So you all know from your health assessment the normal and abnormal vital signs. As you went along in your essentials, your adult 1, adult 2, now you're learning like what's abnormal. And there's a lot of abnormals there. Increased sputum production, fever, respiratory rate is up. His sats are 88% on a non-rebreather.
Non-rebreather, yeah.
Usually non-rebreather, we hook it up to 15 liters of oxygen, so that's close to 100% of FiO2. So that's when I know, like, wow, this patient is very sick, very critical. So the next step would be most likely BiPAP. Depending on his ABG and how he's looking, he might need to be intubated. But he's on the max mask, the non-rebreather. He should be at 15 liters. So, and then I'll make sure his head of bed is up, check his level of consciousness. Do I need to bag him? I will call for help. Let the provider know that, hey, we might need a BiPAP or be intubated. But ABG is important, but I want to let you know, don't wait for that ABG.
That's good.
Because that's not the end all be all. Look at your patient.
Yep.
Do they not look well? Are they declining? They're shallow breathing. They're getting more irritable, more drowsy. Those are your indicators to be like, hey, we need to take action now. We'll get the ABG. It's the same thing with blood cultures and sepsis. Blood cultures are very important to identify the infection, not skew the antibiotics. However, if the patient's severely septic, we're going to start infusing antibiotics because that is the treatment to fix the underlying cause.
Yep.
So again, don't wait, act. Of course, take a moment to pause if you're weighing risk and benefits and safety. But don't wait for certain things when you can actually help resuscitate the patient.
I think you're going back to the analysis of paralysis.
Oh, sorry.
Where you just get, you know what I mean? Where you get paralyzed, like what you're talking about. Yeah. Don't get paralyzed like, hey, we really need an ABG before we do that, but they're blue.
Yes, exactly. We know their ABG is going to be poor.
Yeah.
You could just look at them. Yes, sometimes the body takes a little bit to catch up to reflect the numbers, but they will catch up for sure. You don't want them to be at that point where they're coding. So
good. So what conditions jump out to you when you look at shortness of breath, sputum production, low-grade fever? What are you thinking?
So infection, respiratory failure. He might have pneumonia. It's hard to say, but the sputum production is kind of indicating to pneumonia. Yes, it could be bronchitis, but why I'm thinking pneumonia, usually when it starts getting down into the lungs, that's when they really start going septic and they start presenting with those abnormal severe labs and vital signs.
Good. So hopefully you guys came up with some of those early interventions and things that we can do for this patient.
Oh, real quick.
So we have a follow-up too.
What would be a priority diagnosis? Would it be infection or respiratory?
Good. So when you're looking at, that's a good one too. What do you think? So if you're looking at a patient that is hypoxic acutely, we need to control their respiratory failure first. Yes. So like if they need BiPAP, intubation, whatever, I'm going to do that before I hook up the piperacillin, tazobactam, the antibiotics.
The antibiotics, because at this time, they're going to code from the respiratory failure. Yep. Yes, eventually the infection will get them, but they're going to code from the respiratory failure. Also, what I tell my students, that whole ABG, that whole curve.
The curve, the hypoxemic curve. What is it called? Oh, I know what you're talking about. You'll have to put it in the comments.
So I don't get into the whole left and right shift. There's like a left and right. But what I really want my students to know is 90% of oxygen equals 60 millimeters of oxygen in the blood. Yeah. And that meets respiratory failure. Yep. Yes, do look at your patient, look at their history, what is their usual baseline. But if you just know those two numbers, you're like, oh, 90% is actually this in the ABG. And my patient's not looking well. We need to take action.
Yeah, so what she's talking about there too, just to recap so all of our learners know at home, when I put that sat on my finger and I have a good sat and they don't have nail polish and their hands aren't cold and everything's there, my saturation when it's 90 should be 60 ABG. Yeah. And so the key takeaway from that is if my patient's satting bad, they look bad, Don't wait for a bad ABG to
Yeah.
confirm everything you already know.
No, yeah.
So treat your patient. We used to say this all the time in EMS. Treat your patient. Don't treat the monitor.
Yes.
If my patient has a heart rate of 45 and they look good, that's much different than a 45 and looking bad.
Yes, and their blood pressure is stable at the time. Sometimes we don't have to take action right away, but again, we want to plan and anticipate and have the equipment ready, because when they do actually meet and decline, then we're going to resuscitate.
Good. So let's go to the next part of this case. So his ABG shows a pH of 7.28, a CO2 of 58, and an O2 of 52.
So 7.28.
Let's let the learners real quick. I'm going to say it one more time for you. You guys analyze it at home. pH of 7.28, CO2 of 58, PO2 of 52, currently on 15 liters. He's somnolent but arousable with a blood pressure of 135/78 and a heart rate of 110. So what are you guys at home thinking right now or driving in your car? What does this pH mean? So diagnose it real quick. What does that pH mean? And what are you going to do next for the patient?
And also with the ABG, it's like a math problem. And I know some of you don't like math, but you have to learn math for nursing. Start with the pH first. Is it up or down? Is it acidotic or alkalotic? And then move on to the CO2. Is it up or down? Is it acidotic or alkalotic? And then the bicarb, you're going to do the same. And then what is actually matching the pH? What is it actually? What is the system causing the acidosis? So now I've already identified the pH is acidotic, 7.28. Now, which system is causing that? And when he gave the ABGs, it looks like the CO2 was causing that acidosis. More CO2 is more acid, less CO2 is more basic. So he's in respiratory acidosis. And by identifying that ABG, we realize, we have to get rid of that CO2. I'm going to be honest, with him being somnolent, BiPAP is not going to cut it. We're going to need to do intubation, protect the airway, and help with the ventilation.
Good. So she brings up some great points. Arousable, somnolent, that means your patient might groan when you rub them, but they're almost unresponsive.
Yes.
And you have to ask yourself, if the patient has no chance of recovering from their current state, given what they have, right? We need to do something. And that's where I want to stress to you guys too, that CO2 is never going to get better with a non-rebreather, because it doesn't help their ventilatory status.
Oh, a non-rebreather. So what that means is you want to make sure that bag of the non-rebreather is blown up with oxygen when you put the patient on. So you might have to hold the tabs down to get it to blow up with oxygen. But all we're doing is making sure they receive oxygen and they're not rebreathing their CO2. It's not going to help blow off CO2, but we're going to prevent retaining, hopefully, more CO2. But with the respiratory status and their ventilation, they're going to retain more CO2.
Good. So let's go through some key takeaways. We talked about a lot today. So we talked about diagnosing respiratory failure. So we distinguished hypoxemic versus hypercapnic. And then we talked about intubation. You talked about intubation. You said that, some of the priority nursing interventions, the DNR status, the DNI, some ethics with intubation, terminal extubation, hospice. And then we moved into, some of our case scenarios that we've had, like specifically during the pandemic, that we had some of these really sick patients that required high levels of O2. You talked a little bit about barotrauma can result from those things, from the forced volume. And then we moved into a case, which I think brings us to a great point. The case highlighted just what respiratory failure is and why a patient would need to be intubated. So is there anything that you think I should have asked you today, or anything that you think the learner needs to know from respiratory failure that we didn't cover?
I think we hit the major concepts and the nursing management. And a big thing is you're doing the nursing process without realizing it. And if you get nervous, just take a deep breath and pause for that moment. And then, do the first thing that comes to your mind. I would always call for help first, because the more hands, the better, the quicker the interventions that will occur. Time is better outcomes, something to think about. But that it's okay. It's okay to be nervous. I'm going to be honest, I'm always nervous when I walk into a new patient room or a new facility, because I just don't know them. I take that deep breath Sometimes I just do a brief introduction if they're not in distress. But if they are in distress, then I'm like, oh, I am Sarah. I'm be your nurse today. I'm going to help you. I'm just going to get some more people in here to help us with some interventions, if they are alert or if they're still oriented. But just remember that you know this, and it's okay to ask for help, and it's okay to breathe.
Awesome. Well, thank you guys so much for joining on our first edition of the M&M podcast.
Dr. Mosier, Mrs. Martinez, our last names.
Thank you guys. Have a good one.